31 years old, with acute dislocation of a C joint. Is a left shoulder. This is X-ray pre-op, and this is important at this part because we have to control that the right position of the medial border of the clavicle that is free to avoid that the movement of the clavicle. This is the skin incision, 5 centimeters long, and then the tissue are spread blunt, and you can also palpate the base of coracoid. Now I'm detaching and dissected of the anterior superior, in the anterior superior clavicle, the deltoid. Okay, this is a retractor. And this is a spatial aim. In the picture-in-picture, there is a video that show and explain step by step on bone how the system works. This is a K-wire and a drill over the K-wire, and the spatial aim that avoid to create a problem with neurovascular structure. This is the position from lateral to medial. It's important to be sure to be exactly on the base of coracoid and control. And this device protects neurovascular structure. This is the ballet, and by the ballet you can check that you are in exact position. This is the K-wire. By this spatial aim, you have not a problem because all the step is controlled, and the K-wire stop on the hook of this spatial device. Then drill, and then with the ballet control and check that we are exactly in the middle of the coracoid. Meantime, we prepare the flip tack construct with the 2 flip tack. This is 80 bond cord, control that all part move. This is the flip tack pusher. The flip tack is mounted on the flip tack pusher, and this is also bone demonstration. Then in live surgery, this is the flip tack inserter. Remove the ballet. This is to avoid and to check in easy way the hole that we have do before. And the flip tack pusher can push the flip tack under the coracoid, and without to remove it, you can flip the flip tack under the surface of coracoid. Now I control that the flip tack have flip. You can see that all the shoulder move, so I'm sure. And now I have to repeat this procedure on the clavicle with the same device. It's important in this step to be sure to be in the third posterior part of clavicle, because to put this augmentation in anatomic position as possible. Because we must remember that the ligaments are not perpendicular to the clavicle, to the coracoid. So from posterior to anterior, about 55 degrees inclination from posterior to anterior. This is the correct position. We have drill over the K-wire. This is the step of drill. All these steps are sure because we have the control on the tip, on the hook of the special device. This is all that allow us to put the suture into the hole through the clavicle. And then I can catch the suture under the surface of clavicle in easy way. I remove the loop. And so the passage suture is passed through the threaded loop. Okay. So I can pass the flip tack through the clavicle. Now I set free the end of part of the 80-bond cord. Now I move the 80-bond cord to be sure that there is not a loop inside. So you can see that this is a dynamic stabilization because I move in easy way the end part of suture cord. By pulling on the thread loop. So it's important, I stop the video because it's important to evidence these instruments that allow us to put in the same plane the clavicula and acromion, and to avoid the movement of clavicula and anterior to posterior to anterior. So, and the arm is positioned at about 90 degrees to control it, to avoid the overtime of the suture, because as you know very well, at 90 degrees the clavicle turn about 45 degrees. So by this way I avoid the overtime of the suture, and I put in the same, exactly in the same plane the clavicula in the acromion. And then, using this SC repositioner, the clavicula is set to the acromion perfectly, and then the suture cord of clavicular flip tack is noted. But I created this note without any tension on the suture, because there is the special device that puts the two bones in the same plane. I create normally 4 nodes, and the procedure is finished. It's very easy. This is the first control at 30 days. That's all.
Thank you. Maybe we can go on with the discussion about this AC joint, because it's fresh now. Any questions from the audience? You present this. This is a fresh, I mean, the very acute case.
Acute case. I think that 4 or 5 days after the injury.
So we all know that the problem is when you have a chronic case.
This is not indication. In the chronic case, we use this only as augmentation. You have to do another procedure. The indication of this procedure is only in acute and subacute case. Absolutely.
Yes, I would just like to ask you, what do you use for a chronic case?
We use another kind of ligament, and we add an arthroscopic part to remove a part of clavicular. So it's different procedure. It's not this one. And the indication is to use this only in acute and subacute, and in chronic is used only as augmentation. This is it's important to evidence that this procedure is, I think, the only one that allows us to put exactly in an atomic way this augmentation. Instead of the other procedures, like as in arthroscopic way, you are exactly perpendicular. So there is a big difference between this procedure and arthroscopic procedure. I prefer this one. I started with arthroscopic procedure, but now I perform only in this way by mini open to avoid to clean much more under the surface of coracoid. But the main problem and the main difference is that by arthroscopic way you are exactly perpendicular and in coaxial way. By this way, the two holes on the clavicle and on the basis of coracoid is in different plane, so you can control the movement, the anterior subluxation of clavicular in easy way. The force is different because you have not in perpendicular, you have about 45 degrees, so the force is different, and we have a control at 2 years, and we have no case with, how can I say in English, snow show effect on the clavicula. I think that is because we are in much more anatomic position, and because we are not perpendicular, we put this tunnel on the clavicula from posterior to anterior. This is what we think, and this is supported by mechanical studies.
That's interesting.
Boris,
Here,
what's mean chronic? Because I have
Yes.
different results in a case of 7 days, but after
After 1
20
month.
days, 25 days is 1 month.
No.
1 month
Yes.
chronic.
In our study that we have just shown, we consider acute and subacute 21 days. After, for us, is chronic. Normally, we are able to perform this procedure at 7 days, 10 days after the injury.
it's from 15 to 20. It's
20,
it's-
yes. I
it's-
think that
So it's interesting, this study, because a lot of people does this arthroscopically, and with the use of this AC tide rope, this is similar,
bond.
the same. This is actually the same as AC tide rope, or this
No,
this
it's
is yours, your special device.
No, the device is a device by Storz. It's not
Yes.
my device. I changed something in the instrumentation only, and something in the technique. Now we are performing a new technique about this with the 2 flip tack on the clavicle, and but we are not able to show to you because it's not a CA certificate. So here we show only with only 1 flip tack on the clavicle. But I think that if we create a device as anatomical as possible, it's better for us to reproduce exactly the biomechanical of the corococlavicular ligaments.
But probably you can use this later, maybe also by arthroscopic means. So because you said that the only problem is that you cannot see the base of the coracoid arthroscopically, or
No,
what is the reason?
I
And the tunnel of the clavicle.
I think that I prefer this system than arthroscopic way for 2 or 3 reasons. One of the most important thing is that arthroscopic way you have to clean very well on the basis of coracoid. You have to control exactly. So you have to remove important part of tissue of ligament. We must remember that this is only in augmentation on a fresh destruction of ligament. So if you have to remove this part of ligament, you can have some problem for healing of this ligament. And another is the time, because it's very short time. Procedure is mini open. So, and it's possible to perform this not only a skilled arthroscopic surgeon. So this is another main important part for us.
Excuse me, Ferdinando, you say that the problem of the arthroscopic procedure is that you perform the drill hole perpendicular one each other.
Coaxial, pardon my
Coaxial,
bad,
okay.
pardon my
I
bad
think
English.
that it's possible to perform your technique the same in arthroscopy, separating the two drill holes. So I don't think that the problem is the arthroscopic technique. I think that the problem is that you prefer the open between the arthroscopic procedure for many reasons you have explained. But I think that your instrument could be also used in arthroscopy.
Yes.
Performance. So I don't think that the coaxial drill is the most problem, or not.
It's not easy to perform two hole not coaxial. Normally you have to put this your KY, your overdrill in the same part and very stop way, so you maybe have a problem. This instrumentation start in arthroscopic way, that's true, but now we prefer to use in mini open, absolutely.
Ferdinando, do we have the problem with the knot, security knot of the device, because lie just under the skin and sometimes can give problems, intolerance?
Yes, sometimes you have a problem with the knots under the skin. For this reason, I don't know if I show in very well way, we detach some part of deltoid or and the fascia, and at the end of procedure we try to cover this part, and we are trying to change the notes, not the standard notes, but sliding notes we are thinking about, because we have some problem, but this is a transitory problem, only for a few weeks. So, but it is correct. This is a just a little bit problem. I don't talk about the complication of this procedure.
Any other question? Maybe we do we have contact with the theater maybe to see?
Okay.
Thank you
That's
very
all.
much.
Thank you.